I'm Nancy Kuntz, a child neurologist in Chicago. I'm a professor of Pediatrics and Neurology at Northwestern University Feinberg School of Medicine. And today we're going to be talking about treating spinal muscular atrophy. Just briefly to remind us, spinal muscular atrophy is an autosomal recessive genetic disorder where lack of functioning SMN1 gene leads to absent or very low amounts of SMN protein. Actually, humans have a backup SMN2 gene that produces trace amounts of functional SMN protein, without which the disorder would be intrauterine fatal. But with this reduced SMN, most obvious clinical presentation is weakness, hypotonia and weakness. However, we now realize that the functioning of SMN1 and SMN protein is to support splicing of RNA as it forms protein, and therefore it affects really all body systems, but somehow the motor neurons take the biggest hit in function. We have discovered that common sense treatment to support nutrition and ventilation and just general health in spinal muscular atrophy makes a really big difference in terms of how the children are followed. The children have mobility problems, and so I believe it makes sense to have a multi-specialty clinic where multiple professionals and disciplines can make themselves available to the children with one visit. Otherwise, with the difficulties bringing the children in repeatedly, many times they don't get to see all of the different specialists. And there's no question that nursing for education and orthopedics to help monitor bone health and scoliosis and joint complications, and neurology and neuromuscular background now to not only diagnose but to help treat the spinal muscular atrophy, pulmonology to help with the ventilation, and those complications are very, very important, as well as genetic counselors to meet with the family and inform both the family and their extended family about the potential for recurrence, as well as the potential for treatment in future cases of spinal muscular atrophy. Well before the current era, where we have FDA-approved treatment for spinal muscular atrophy, we were able to show that just very careful, detailed, comprehensive care improved the outcomes. And so you can see here just survival curves, one of them just looking at frank survival, and the other one looks at survival without supportive ventilation. And you can see that with the solid line being the oldest, going between 1980 and 1994, and then a newer generation with the dotted lines being children who were born between 1995 and 2006, you can see that just these robust, supportive cares made a big difference in terms of survival and well-being. There have been two efforts, with the most recent one being having been published just in 2018 in the journal titled Neuromuscular Disorders. And this was an international panel that got together with individuals from all of the disciplines we just talked about and really put their thoughts together about basic issues that really should be addressed in the care of every individual with spinal muscular atrophy. And as you read these wonderful articles that sum the consensus of the specialists, I think that you can understand that it's much more efficient to provide that, when possible, through a multidisciplinary clinic. In general, we find that seeing the children about every 6 months makes a difference. Many times there have been changes in their motor skills. Definitely would be the potential for there to be changes in their range of motion or flexibility. If there are changes in any of the strength of the bulbar function having to do with swallowing, or the intercostal muscles relating to their ventilation or breathing, that can provide the signal for additional layers of supportive care and to be provided with training and equipment provided to the families to keep the children healthy and out of the hospital. In most communities, metabolic bone health is managed differently, sometimes nephrology, sometimes endocrinology, sometimes orthopedics. In our clinic, we have an orthopedic nurse practitioner who is, several of them, who are very well trained in how to monitor bone density and bone health and how to promote bone health to prevent fractures in individuals who are less mobile. In addition, many of the individuals who have been weak with spinal muscular atrophy, certainly all of the prevalent cases that exist in your clinic, are at great risk for scoliosis. And I think that having newer ways to manage the scoliosis, with bracing sometimes used, and now people moving into surgery that is a little bit less invasive and that can be implemented earlier. For example, growing rods that can either by re-intervention and repeat surgery or through use of magnets be extended and grow with the children, allow intervention in scoliosis earlier on without having to wait for the child to finish their growth, which frequently is associated with attaining more significant degrees of scoliosis. I put this in here to remind us that tongue fasciculations, or just that little wormian-like movements that occur irregularly, involuntarily, but usually persistently in the tongue when there is ongoing denervation, are one of the things that we look for classically with some of the more severe cases of spinal muscular atrophy. When those things are present, it's very important to evaluate the swallow to make sure that it's safe, to make sure that the children are protecting their airway when they swallow. And if that's not the case, or if simple measures like increasing the texture of their intake doesn't cure the problem, then moving ahead with parenteral nutrition with feeding tubes or NG tubes are important. Again, multidisciplinary treatment teams make a very big difference in the life of children with spinal muscular atrophy. And having children with all of those detailed and careful interventions made available to them has allowed us to do wonderful clinical treatment trials where we have all the children relatively on an even playing field, so that the only difference or new intervention would be the treatment, so that it can be clearer earlier on with smaller numbers and to significantly power the study whether the new treatment is effective or not. We've been fortunate enough to have now 2 FDA-approved treatment trials, as you can see in this drug pipeline cartoon from Cure SMA, with another oral agent having been submitted for consideration by the FDA, and several things under consideration for treatment of spinal muscular atrophy. I'd like to very briefly talk about mechanisms of action of the commercially available treatments. And we have 2 different mechanisms of action identified on this cartoon. The first that was approved was exon skipping. A very targeted treatment was created with an antisense oligonucleotide that aimed for the part of the SMN2 that it interfered with exon 7 being incorporated well. So most of the poor protein that doesn't survive has exon 7 skipped, and this ASO targets that exact mechanism and reorders it in a way where with the read through the exon 7 is incorporated, producing virtually 100% functional SMN protein from the SMN2 gene. This is something that is administered intrathecally because ASOs don't cross the blood-brain barrier. The current medication is something that has to be given in 4 loading doses over 2 months, and then repeat maintenance doses are given every 4 months. So it means repeat lumbar punctures. There is work going on to try to lengthen the half-life of these agents, or this agent, as well as to come up with a good delivery system so that reservoirs or some other mechanism of delivery will get the medication into the spinal fluid without the lumbar punctures every time. As you can imagine, those individuals who already have advanced scoliosis or who've already had spinal surgery have more complex issues with delivering the medication to the spinal fluid, but it could still be done, and they have benefited in our experience to date. The ASO agent that I've been discussing is called nusinersen, is the generic name. A newer treatment that has been approved, but rather than for all ages and types of spinal muscular atrophy like the first agent, the ASO, there is approval for children who are under 2 years of age of gene replacement therapy, where SMN1 has been packaged in an AAV or adeno-associated viral type 9 capsid and then administered intravenously in large numbers as a single dose. There have been now up to 4 to 5 years of experience with the first children who've been treated, and so the safety and the long-term benefit appear intact, but there are ongoing trials with older and larger children. Onasemnogene abiparvovec is the name of the SMN1 gene replacement agent that has been used in association with an adeno-associated type 9 virus. It's self-complementary and has been observed to very quickly produce SMN1 and sustain SMN expression over time. There is another FDA submission that's under consideration at the end of 2019. It's an oral agent. It's an ASO, a small molecule actually, that is less targeted but has the same impact on the SMN2 gene to improve the splicing and inclusion of exon 7 so that the survival motor neuron protein is produced. So in summary, spinal muscular atrophy is a progressive neurodegenerative disorder. Actually, the absence of SMN protein affects all cells in the body, but the impact is greatest in the motor neuron system. We have observed through watching many individuals with SMA that the supportive cares involving support for nutrition as well as ventilation are things that make a very big difference in terms of well-being and comfort and quality of life, and has brought us to the era now where we have multiple commercially available treatments for SMA that will make a very big difference. And that's why educating all of us as clinicians to make certain that we consider SMA in any potential patient in the differential diagnosis and move quickly to either make the diagnosis or exclude it as a potential diagnosis, and then treat SMA if it's present as early as possible.